supported by parental supervision, early intervention and appropriate surgical treatment can result in good visual outcome. Thank you.
Thank you, Doctor. Next, we'll call upon Dr. Keshav Kumar, who will be presenting on an unexpected visual outcome in a case of open globe injury.
I am presenting case of unexpected visual outcome in case of open globe injury. Open globe injuries are full thickness defects of the eye wall and are often differentiated by the mechanism of injury from which they are caused, that is sharp or blunt trauma. They are ocular emergency and can lead to substantial visual morbidity. Without timely intervention, damage is irreversible and lead to permanent vision loss. This case is a 17-year-old male presented to the ophthalmology emergency department with complaint of pain and sudden loss of vision in right eye, followed by trauma with sharp object. On examination, his visual acuity is hand movement and PLPR was positive. Extraocular movement free and fully in all direction, and eye was digitally soft. On examination, there was mild lid edema and full thickness horizontal sharp linear laceration present from 4 to 8 o'clock in cornea, which is extending up to 7 mm in sclera along with uveal tissue prolapse. Blood stained vitreous and pupil was eccentric. Management. Patient was shifted to emergency OT after required blood investigation and X-ray headed orbit after ruling out any intraocular foreign body, abscission of prolapsed uveal tissue, meticulous repair of corneal scleral tear with interrupted suture, reformation of anterior chamber with basic salt solution and air to maintain the IOP, closure of conjunctiva with suture and BCL was placed. On post-operative care, there was systemic antibiotic, analgesic and steroid were given, and local antibiotic eye drop and cycloplegic eye was on day 1. Hand movement, visual acuity. On ocular examination, there was subconjunctival hemorrhage, 10 corneal and 6 scleral suture are in situ, and AC was found air within the AC, and lens was clear. And follow-up first week, visual acuity was 660. On examination, there was mild conjunctival congestion, corneal suture was in situ, and pupil was in situ. On fundus examination, there was multiple choroidal fold were present. Follow-up after 6 weeks, patient's vision dramatically improved up to 6 by 12, suture removed, BCL was rested, and on posterior segment examination, B scan were normal. In this case, in spite of having zone 3 ocular injury and category 2 trauma score, patient had exceptionally good visual outcome, which was in contrary to study done by Joe et al. Early intervention in sharp object related open globe injury had good visual prognosis, as opined by study done by AIOC et al., which was also found in our study. Timely evaluation and treatment on open globe injury is necessary to reduce vision, morbidity, and mortality. Evaluation should be done quickly to identify open globe injuries and characterize the injury, prioritizing expenditure to surgery. Adequate surgical exploration along with meticulous suturing should be done to prevent further leaking of wound. Analgesics, antibiotic, steroid, and eye protection are necessary to prevent further complication.
Were any pre-op investigations done?
Blood investigation and X-ray head and orbit to rule out metallic foreign body in intraocular.
Okay. All right, doctor. Thank you. Next, we'll call upon Dr. Vishnu Swaroop, or Dr. Ridhima, for traumatic iridodialysis, a double Kate way to die.
Good morning, everyone. My case today is of traumatic iridodialysis. Coming to the epidemiology, the purpose of our study was to highlight the challenges one faces in the management of traumatic ocular injury and to avoid subsequent blindness due to the same. In North India, 4% of all avoidable cases of blindness have been attributed to traumatic ocular injury, and 20% are due to occupational injury due to construction. 16% of all the occupational eye injuries were considered serious causes of monocular blindness, whereas 7% of them were causing binocular blindness. And the main age group involved was from 20 to 64 years of age. Males, of course, more common as compared to females. So the case was of a 37-year-old male residing in the suburb of southwest Delhi, India, with a low socioeconomic status who came to a district hospital with alleged history of occupational injury to the right eye with a stone while working at a construction site 15 days back. He had no known comorbidities and no previous history of glass or protective eyewear and no comorbidities or addictions. On examination, his visual acuity in the right eye was finger counting 1 meter, not improving on glass or pinhole. Color vision could not be assessed because of the poor vision. Intraocular pressure was 32 millimeters of mercury on Goldman applanation tonometry. Gonioscopy was found to have angles that were closed with Schwalbe's line pigmented in 3 quadrants and tears in the root of iris superiorly. There was circumciliary congestion in the conjunctiva with anterior chamber on VH grading was VH1 and 1 plus cells in the AC. Iris showed superior iridodialysis at 11 to 12 o'clock position. The pupil was D-shaped and grade 3 RAPD on neutral density filter was seen. The lens showed a complicated traumatic cataract. These are the gonioscopy findings. The left eye, there was no, everything was within normal limits. Coming to the fundus finding or the posterior segment finding, we saw that right eye had grade 3 papilledema on Frieson's grading on slit lamp biomicroscopy. OCT macula done and was normal in both eyes, and B-scan was also anechoic. The OCT RNFL showed a marked increase in the OCT RNFL thickness, suggestive of disc edema in right eye. The MRI brain with orbit on T2 weighted axial scans showed mildly dilated perineural fluid with subtle fat stranding which was seen around the right lateral rectus, suggestive of right eye optic neuritis. On our management, on day 0, the patient was given intravenous methylprednisolone 1 gram per day for 3 days, followed by oral prednisolone 1 mg per kg for 11 days. And then intravenous mannitol was given 300 ml of 20%. A color vision was recorded and right eye visual acuity regained. Then we went for a lens aspiration with a 3-piece intraocular lens implantation along with iridodialysis repair with adequate pressure control. Iris tear repair was done with alternate iris bypass technique. Visual acuity was gained on day 60 and the patient is still being followed up. These were some of the intraoperative pictures and there were no financial disclosures with complete ethical clearance that was taken. So coming to our conclusion, the glaucoma occurring in such a case of trauma is not due to typical angle recession, which is a type of open angle glaucoma, but can also be due to secondary traumatic cataract or phacomorphic type of glaucoma. Hence, a gonioscopic evaluation is very important and a dilated fundus examination was very important in our study with consecutive follow-ups till at least 12 months. Thank you.
Thank you, Doctor. Next, we'll call upon Dr. Sakshi Locha. Dr. Sakshi. Is Dr. Shubodh here?